بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Dear colleagues, I'm Dr. Hanan Al-Rayes, consultant rheumatologist and the president of Saudi Society for Rheumatology. On behalf of Saudi Society for Rheumatology, I would like to welcome you all in Best of ACR Convergence webinar. This year has been a year unlike any other. All of us have adapted changes and challenges we have never encountered previously. What did not change was that individuals were still diagnosed with rheumatic diseases, suffered, and some unfortunately lost their battle to the rheumatic disease. This is why sharing this year's significant scientific advances from the American College of Rheumatology Convergence meeting was a high priority for all of us in the planning committee of Saudi Society for Rheumatology. As such, I'm pleased to welcome you to the official Best of ACR Convergence Saudi Arabia program that will feature presentations by renewed international faculty as well as regional key opinion leaders. Over the next 4 days, we have planned an excellent presentations in both adult and pediatric rheumatology. Tonight's agenda features, in the adult session room, we will cover mainly rheumatoid arthritis and specifically about clinical treatment approach in adult rheumatoid arthritis by Professor Vivek Strand. And we have with us also Dr. Siham Al-Rashidi, which she will talk about the most relevant topic, timely topic, which is COVID-19 and rheumatic diseases. In the pediatric session room, we have Professor Karen Brand O'Neill. She is the chief of the Pediatric Rheumatology Hospital for Special Surgery at Cornell Medicine Hospital, who will discuss the 2020 ACR Juvenile Idiopathic Arthritis guidelines. Tomorrow, in the adult session, we will hear from distinguished faculties from ACR faculties about evidence on myopathic rheumatic diseases, renal, systemic lupus erythematosus, as well as antiphospholipid syndrome. Leading the presentation and discussion in the pediatric session room tomorrow will be Dr. Muhammad Ahmed Mudaffar from King Abdulaziz University College Medicine. The session will include a novel topic of pediatric COVID-19, hyperinflammation, which will be presented by Dr. Ghada Al-Salami. On December 20, we will join together in one session room for update in non-renal systemic lupus erythematosus, primary Sjogren's syndrome, and systemic sclerosis, gout, as well as osteoarthritis. Our final sessions on December 21 will feature Professor Robert Inman, who will talk about spondyloarthropathy. In addition to that, to these official sessions, you will cordially invited to attend the industrial symposia being held by our supporter, as well as to visit our virtual exhibition hall, which will allow you to discuss treatment advances and connect with the representative of each company. On behalf of Saudi Society for Rheumatology, I would like to thank all our supporters. I would like to thank all distinguished speakers, chairpersons, and special thank to the organizing as well as scientific committees who did major work in the last month preparing for this Best of ACR Convergence 2020. For complete program with timing, please access Documents tab in the website as shown on screen. Finally, I would like to thank you for taking time out of your demanding schedules to attend our virtual program. I'm confident that your time invested in attendance will be rewarded with an advancement in your clinical skills and will improve patient care outcomes. I hope all of you stay well and we can be together in person for the next year, inshallah, in the official Best of ACR program. Thank you all. And now we'll start the session in the pediatric room. Our chairperson is Professor Suleiman Al-Mayouf, who is known for all of you. He's a consultant of pediatric rheumatology at King Faisal Specialist Hospital, and he's a professor of Medical College Al Faisal University. Professor Suleiman Al-Mayouf, he got his fellowship in pediatric rheumatology from Sick Children in Toronto. He is a board member in the Society for Rheumatology for the last 10 years. He is very active in the research area. He got a lot of publication. He is the national coordinator for the Pediatric Rheumatology International Organization. And Dr. Al-Mayouf has more than 130 publications in scientific journal as well as many abstracts. He is a frequent lecturing nationally as well as internationally in pediatric rheumatology. So welcome, Prof. Suleiman, and the chair is you now. Thank you.
Good evening for everybody. Good morning, Dr. Karen O'Neill. Thank you everyone for being with us tonight. I am Suleiman Al-Mayouf, pediatric rheumatologist from King Faisal Specialist Hospital, College of Medicine, Al Faisal University, Riyadh. On behalf of the Saudi Society for Rheumatology and in partnership with ACR, I would like to welcome you to this unique scientific activity. For the first time, the SSR, in collaboration with the ACR, the scientific committee, with help of outstanding speakers, bring the best ACR 2020 over 2 days. For tonight, we will have 3 excellent presentations. I'm confident that you will find the presentation interesting and worthwhile. Please put your question in the Q&A box and we will go through them. We will have discussion after each presentation and I'm sure it will be a fruitful one. Without further delay, I am really excited to have Dr. Karen O'Neill. Dr. Karen O'Neill is the Chief Division of Pediatric Rheumatology, Professor of Clinical Pediatrics at Weill Cornell Medicine Hospital for Special Surgery in New York. Dr. Karen has authored numerous papers, reviews, and book chapters on pediatric rheumatology. She is well known as reviewer for several scientific journals. Dr. Karen will present the new GIA guidelines. Dr. Karen.
I'd like to thank the organizers for inviting me here today to discuss the 2020 ACR guidelines for the treatment of juvenile arthritis, therapeutic approaches for oligoarthritis, TMJ arthritis, and systemic GIA, as well as medication monitoring, immunizations, and non-pharmacologic therapies. I have no relevant financial disclosures to disclose. Please note, this presentation contains draft recommendations that are pending full approval from the American College of Rheumatology. And these recommendations are intended for children in whom the diagnosis of GIA has already been made. What is our plan for today? We're going to review the 2020 ACR guidelines for the treatment of GIA. We'll learn how to apply these new guidelines in practice and also have an opportunity to review pertinent presentations from ACR Convergence 2020. So what's the rationale for this update? Well, the American College of Rheumatology periodically updates topics of importance, and the plan was to cover all topics relevant to persons with juvenile arthritis using a novel methodology referred to as GRADE, and GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. GRADE incorporates evidence with explicit consideration of the values and preferences of patients and society at large to arrive at recommendations. GRADE specifies as an approach to framing questions, choosing outcomes of interest, and evaluating the evidence. And since it's relatively new, I'll walk you through this process. So how does this work? Well, the most important part actually is to ask the questions that are called PICOs. And this refers to patient population, intervention or issue, comparison intervention, which is option, and outcomes of interest. Once you've established what are the questions that you'd like to ask, then the literature review takes over. It identifies and assesses studies that are quality assessed. Recently published systematic reviews covering the outcomes of interest are sought and references are cross-checked. And then evidence is downgraded or upgraded based on confounders and bias. And the evidence is then rated as to the quality or the certainty of the evidence. And it can be rated as high, moderate, low, or very low. And as you'll see, most of the evidence that supported these recommendations, unfortunately, is low or very low. The certainty of recommendations is also very important, and these recommendations can be strong, in other words, confident that the desirable effects of the intervention outweigh the undesirable effects, and they would apply to most patients, all patients. Conditional would say that the desirable effects probably outweigh the undesirable effects of intervention and apply to most patients, but are also preference sensitive. And you can see here that you can be strong or conditional in either direction. You can be strongly for or strongly against an intervention, and likewise conditionally for or conditionally against. After that, voting takes place. First, the patient panel votes. We met days before the voting panel meeting and provided unique patient perspectives and drafted recommendations. The voting panel had 2 votes, first individually, which was anonymous, to see if consensus might or might already not be there, and then to develop the agending for the meeting panel. The second vote was face-to-face, which in 2020 means Zoom, 16 hours in total, where we discussed the evidence, clinical experience and expertise, patients and family preferences, and then we had to generate consensus on the final recommendations. We had to achieve at least 70% consensus. And we voted both on, again, strong, conditionally for, conditionally against. So this process was started actually in 2017 when the ACR decided to update the original recommendations that had been made in 2011 in response to the fact that there have been great interventions that have been discovered since that time. But it was very clear upon starting that this was going to be too large for one group to manage. So the first set of recommendations, which were published in 2019, included non-systemic polyarthritis, sacroiliitis, and enthesitis, and a separate manuscript dealt specifically with the screening, monitoring, and treatment of juvenile idiopathic associated uveitis. So clearly that was not going to be able to be done, did not cover all topics. And so a second panel was convened in 2019, and those are the recommendations that I'm going to present to you today. There is some overlap with the first group, but not complete. We made a total of 47 recommendations, not all of which will be presented today. As you see, 2/3 of them were conditional, 1/3 were strong, and the level of quality of supporting evidence, unfortunately, was largely very low, with a few that were low. Now to go through them. When looking at oligoarthritis, now these actually are not criteria-based, but are clinically based. So for oligoarthritis or less than 5 involved joints, intra-articular glucocorticoid injections are recommended as part of initial therapy. And triamcinolone hexacetonide is recommended as the preferred agent. A trial of consistent NSAIDs can be used as part of initial therapy, and oral glucocorticoids should not be added to initial therapy. And here you'll see the stop sign conditional, which is to say should not be used. Non-biologic DMARDs are recommended if there's no or incomplete response or intolerance to NSAIDs or joint injections, and methotrexate is recommended as a preferred agent, with other agents being mentioned as possibilities since methotrexate cannot always be tolerated. And finally, biologic DMARDs are recommended if no or incomplete response or intolerance to NSAIDs or joint injections, and at least one non-biologic DMARD where there is no preferred agent. Now, risk factors including involvement of the ankle, wrist, hip, and/or TMJ, presence of erosive disease, delay in diagnosis, elevated inflammatory markers, or symmetric disease are recommended to guide treatment decisions. As well, validated disease activity measures are recommended. Finally, imaging guidance is recommended for intra-articular glucocorticoid injection of joints that are difficult to assess or to specifically localize the distribution of inflammation. Now, when considering TMJ arthritis, this may or may not be isolated. So what are the differences from oligoarthritis? Well, firstly, intra-articular glucocorticoid injections are recommended but should be restricted to children who are skeletally mature and not repeated. There's a high risk of heterotopic bone formation and growth retardation, and there is no preferred agent. And second of all, with respect to the high impact on quality of life, rapid escalation to a biologic DMARD is reasonable to prevent loss of function. Now, what about systemic JAA? We're going to separate this into without MAS and with MAS. So in consideration of SJA without MAS, NSAIDs are recommended as initial therapy. If there is not an immediate response, then biologic DMARDs, IL-1 and IL-6 inhibitors are recommended as initial monotherapy, and there is no preferred agent. A single biologic DMARD is recommended over a combination of non-biologic DMARDs if no or a complete response to intolerance to NSAIDs and at least one non-biologic DMARD. Now, there has been reports of an emergent high-severity lung disease affecting children with systemic J who are treated with IL-1 and IL-6 inhibitors. These are largely young children who have had reactions to these medications, also children with Down syndrome. Much work is needed to be done to better understand if there is a population at risk, but that certainly does temper these recommendations, which is why they are conditional. Oral glucocorticoids should not be used as initial monotherapy, and non-biologic DMARDs, for instance, methotrexate, cyclosporin, sulfasalazine, leflunomide, thalidomide, should not be used as initial monotherapy as well. Quick word about MAS. MAS is a major cause of morbidity and mortality for children with SJIA. It's a cytokine storm, a secondary hemophagocytic syndrome. It can be seen with any rheumatic disease, but most commonly seen with SJIA. And features include fever, high ferritin, cytopenias, elevated LFTs, and high triglycerides. And because of the severity of this phenotype, recommendations are somewhat different. Glucocorticoids are recommended as part of initial monotherapy. Biologic DMARDs, IL-1 and IL-6 inhibitors are recommended over calcineurin inhibitors in order to achieve inactive disease and resolution of MAS. Again, no preferred agent. Biologic DMARDs and non-biologic DMARDs are recommended over chronic glucocorticoid treatment if there's residual arthritis and an incomplete response to IL-1 or IL-6 inhibitors. There's no preferred agent. Now, what about when these patients attain inactive disease? Tapering and discontinuing glucocorticoids is recommended after inactive disease state has been attained. This is despite the fact that there is potential risk of flare. In addition, tapering and discontinued of biologic DMARDs is recommended after an inactive disease state has been attained as well. Now, the following recommendations pertain to all children with JAA. As regards laboratory monitoring, CBC and LFTs, kidney function should be checked prior to treatment and may be repeated as often for clinical care as needed. For methotrexate, sulfasalazine, leflunomide, tocilizumab, anakinra, canakinumab, and now tofacitinib, which is available, laboratories should be checked 1 to 2 months after starting and then every 3 months ongoing. For children treated with nonsteroidal anti-inflammatory drugs, labs should be rechecked every 6 months. For hydroxychloroquine and TNF inhibitors, at least once yearly, and for abatacept, no specific routine lab monitoring is required. Monitoring lipids after starting tocilizumab and tofacitinib as per package insert is recommended. And for hydroxychloroquine, baseline and annual retinal screenings are recommended rather than waiting 5 months for first screening. 5 years. Now, as for infection screening, this particular issue really depends on where you live. So these recommendations pertain specifically to the United States and Canada. In the United States, tuberculosis, over half the cases are located in only 4 states. So there'll be several areas where there is essentially no tuberculosis and other areas which are relatively high. And for that reason, TB screening should be tailored to where you live. So TB screening is recommended prior to starting biologic DMARD therapy, and whenever there is a concern for exposure thereafter. Screening can be done either through tuberculin skin testing or through interferon gamma release assays. Screening may be done by a questionnaire in areas where tuberculosis is extremely rare. And concern for exposure should be interpreted broadly. Travel, exposure to somebody who's infected, or living in an area where endemic cases of TB are high. We were unable to reach consensus on whether or not to screen for other viral infections prior to DMARD therapy, such as hepatitis B and hepatitis C. And we learned that the risk is really dependent on who you are and where you live. Now, what about immunizations? Children with JIA can respond to immunizations with no increased risk of flare. And so we have a strong recommendations for immunizations whenever possible. So which ones are recommended? We go by the CDC/ACIP and AAP guidelines, including those for annual flu immunizations for all children with JIA. When children are on no immunosuppressive medications, all live and inactivated vaccines as recommended are recommended for children with JIA. What about those who are on immunosuppressive medications? There's a strong recommendation for inactivated vaccines, including PPSV23, but live attenuated vaccines are not recommended for children with JIA on immunosuppression. There is some literature now saying that this is safe for children who are receiving booster immunizations, and that might be appropriate during an epidemic. However, studies haven't been powered to find severe rare events, and for that reason, they are not recommended here. What about special circumstances? So ideally, for children with active non-systemic JIA with no evidence of immunity to MMRV, prior to starting immunosuppressive medications, these children will be immunized and then wait 4 weeks for treatment with an immunosuppressive agent if needed. Use of lyorized vaccines in the household of children receiving immunosuppressive medications are generally recommended with few contraindications, such as smallpox, and we recommend checking local guidelines for specific vaccine questions that might not be addressed here. So how do these actually work in real life? Let's just go through some standard cases and see how you would use these guidelines. So let's take a standard case of a child, a 3-year-old with oligo-JIA of both knees and her right ankle. So she comes to your office, you made the diagnosis, and how do you proceed? So her CJ-DES is 10, which is modest. She has her ankle involved, which is a risk factor. And we'd sit down to discuss with the parents in making shared decision-making about treatment. What are our options? We could start with a non-steroidal anti-inflammatory trial. We could consider glucocorticoid joint injections, and we could consider a non-biologic DMARD. After discussion with the family, we elect to start with a non-steroidal anti-inflammatory trial. We get baseline labs, including complete blood count, renal function, and liver enzymes. And if the patient hasn't gotten their primary series yet, we're going to go ahead with MMRV and have them come back in a few weeks so we can see how the child is doing. She comes back to your office, and unfortunately, she has persistent arthritis. Her CJ-DES is somewhat better, but still elevated. And so we recommend a glucocorticoid joint injection with triamcinolone hexacetonide. We use ultrasound to visualize the ankle to make sure that we're in the compartment which is inflamed, and we make plans after the injection to have her come back in a few weeks. Unfortunately, when she returns in a few weeks, she has persistent arthritis. Now, still in the ankle, but also a new wrist, and her CJ-DES, although improved, is still elevated. And again, we think about what we should do about treatment here. We could go ahead with a glucocorticoid injection of the new joint. We could go ahead with a non-biologic DMARD, such as methotrexate. Now, the ankle and wrist are risk factors, so we could consider the use of biologic DMARD. And the parent at this point wants to go home and think about it, and you make plans to talk by phone the following week. Now, what about a second case, a child with SJIA with no MAS? Similarly, we're going to have his JDAS, and this child has a JDAS of 16, again, modestly elevated. We're going to talk about different treatment options, and these might include a nonsteroidal anti-inflammatory trial, oral glucocorticoids alone, non-biologic DMARDs alone, both of these are not recommended, and a biologic DMARD alone. Family agrees to an NSAID trial, but agrees to come back in a week for follow-up. Baseline labs are completed. Child comes back a week later, still has fevers and arthritis. CJDAS is 13. And so again, talking about treatment options, biologic DMARDs are recommended. A non-biologic DMARD is brought up only if there is significant synovitis, and that would be in conjunction with a biologic DMARD. Ultimately, the family agrees to an IL-6 inhibitor, and tocilizumab is started. Follow-up, the child returns and is now in inactive disease. We're going to check blood counts, liver enzymes every 3 to 4 months. We're going to check lipids every 6 months. We'll discuss vaccination with inactive vaccines to make sure that everything is up to date. And we'll discuss options for tapering, decreasing the dose versus spacing out the interval. As there's no particular recommendation, we don't know which is best. We'll leave that, at least in part, up to the patient and the family. Now, ACR Convergence presented some studies that are really of direct relevance to most of what I've sent to you today. So why don't we just take a trip through some of the interesting presentations. So this first one, presented by Dr. Kimura for the Stop JAA CARA registry and investigators. Stop JAA is known as Start Time Optimization of Biologic Therapy in Polyarticular JAA. And what this study purported to do was, in 400 children, see if JAA came under control best if started with a combination of a biologic DMARD and non-biologic DMARD, a biologic alone, or a non-biologic DMARD alone. And so here we have step up, adding biologic if needed after 3 months, starting both together, or starting with a biologic first. And this is what we found, and most notably, actually, was the fact that this study is an observational study in the sense that a comparative effectiveness study, in that physicians and patients were allowed to choose the treatment that they wanted. And so overall, 400 children, but 257 chose the step-up protocol, and early combination in 100 and biologic first in 43. And I must say, this is at least in part a reflection of the fact that many insurers in the United States require step-up therapy. So starting with a non-biologic DMARD versus starting with a biologic DMARD. And you can see that the JDAS was pretty elevated really across the board, and that the active joint count was quite substantial. And so what you see here is, after taking into account propensity scores and multiple imputations, because there were differences between groups, numbers of patients, that early combination versus the step up did have a higher response, a higher ACR 70 response, and a better CJDAS of low disease activity. But what's not shown here is that inactive disease was not different between groups. So what did we learn here? Well, we can successfully actually enroll 400 children in a prospective treatment study, but that there were no significant differences in inactive disease off glucocorticoids at 12 months, but there was a trend towards significantly improved outcomes in the early combination group using other outcomes measures, such as the JDAS and the ACR 70 score, with more rapid discontinuation of glucocorticoids, which is not shown. And this sets us in a direction where clearly earlier aggressive disease is likely to get you in the right direction faster. Whether or not this is going to matter much over the long term, that's going to take significantly more follow-up. And we have patients that we will be following for the next 10 years to see if that is where the effect actually is seen. And what about this? Distinct pattern levels of response to methotrexate in juvenile arthritis. This was presented by Dr. Shute-Burrell from the UK, and this clearly could have impact if we understood, for instance, which subsets of JAA would respond better to a particular medication, or which group of children within a particular group would respond. Then we would be able to know even better than broad recommendations, but specific recommendations for specific patients. And what they found was that across the board in each subtype, there were differences between children who had persistent disease despite the use of non-biologic DMARDs and patients who were fast responders. And the goal is to identify these children, be able to find a particular cytokine panel or specific factors that mark each group so that we could tailor treatment more appropriately than we do now. Now, what about this? Patient-reported adverse events, quality of life, and treatment adherence in JIA. This was presented by Alessandra Alonghi for Printo and the APOCA study group, and was looking at these two large international cohorts to see if patients' adverse events, as reported by patients, ultimately impacted treatment adherence. And so what they did was they basically asked patients to report adverse events over time and then look to see if these adverse events that the patients reported affected overall well-being, psychosocial HR quality of life, school activity, and finally self-reported treatment adherence. And what you see is that almost a third of the patients had a patient-specific report of adverse events, many of them gastrointestinal, large number of sleep problems, and other concerns. And the adverse events had a significant effect on psychosocial HR quality of life, school activities, and treatment compliance. Mood swings and sleep problems, as well as weight gain, had the highest impact of HR quality of life, but nausea, which was the most frequent adverse event, had a relatively low impact on HR quality of life, but a high effect on medicine compliance. And this too shows the importance of many considerations that need to be taken into a cumulative thought process when we're considering what medications to give our patients. Because if a medication is recommended but has a high level of adverse events, it's unlikely to be useful, patients are unlikely to take it, and shouldn't be recommended as high as other therapies which are better tolerated. And finally, and excitingly, tofacitinib for the treatment of patients with JIA, an interim analysis of data up to 5.5 years from an open-label long-term extension study presented by Dr. Bruner for the Pediatric Rheumatology Collaborative Study Group. And what they looked at was a group of children that had had fairly significant JIA, many of whom did not respond to prior therapy. And what you see with the treatment with tocilizumab, that the CHAC, or the disability index, which was originally mild to moderate, rapidly came down to a mild level, and that the JAI ACR responses were quite high, mostly ACR 70 or 50s, with some ACR 90s. And again, this was a particularly severe group of diseases where children had failed other therapies. Adverse events, of course, occurred. For adverse events of special interest, there were no deaths. There was a case of uveitis, 2 cases of herpes zoster, 1 serious, 1 non-serious, as has been reported in adults, and 5 total serious infections, which do include those patients with zoster. So what have I shown you here today? I mean, this has really demonstrated the evolution for the treatment of JIA. We have decreased reliance on NSAIDs and glucocorticoids and earlier introduction of biologic DMARDs. And although the evidence remains low and many recommendations are conditional, the inclusion of parents and patients in the making process strengthens their validity. And finally, it's important to remember that these are just guidelines. Clinical care, as always, remains in the care of the care provider and patient. Thank you so much for your attention.
Thank you very much, Dr. Karim, for this excellent presentation. We'll have 5 minutes for discussion. Probably I can start with the first question while we are waiting for questions from the audience. It's noticeable that glucocorticoids was not considered as initial treatment for systemic GIA without MAS or NAS. So is there a reason for that?
The reason that we selected to go to the biologics first is because they are highly effective in stopping the inflammatory response quickly. And the feeling is, in reviewing the literature, patients' preferences, physicians' experiences, that much of the morbidity that we see for systemic JA is directly corticosteroid related. And so if possible, we're trying to avoid that in a particularly vulnerable population of young growing children.
Yeah, because I noticed that you consider NSAID as initial treatment, and we know from the real practice, NSAID will not work for most of the patients.
That's absolutely correct. And the reason that that's written that way is really a patient preference issue. So we know that NSAIDs will work in about 23–25% of patients with very mild disease. But the plan would be that for anybody who didn't have exceedingly mild disease to go directly to a biologic, and otherwise to give a very, very short course of NSAIDs really as a bridge to obtaining or getting parental agreement to move to a biologic.
Okay, but in situation with limited access to biologic, what is your, I mean, if there is limited access to biologic, what recommendation to go for conventional DMARDs? For instance, would you recommend cyclosporine, methotrexate, or maybe combined conventional DMARDs?
In that particular situation, remember, these are U.S. guidelines, well, U.S. and Canada, since some of the people on the panel were Canadian, that we know what we have access to. And indeed, your point is exceedingly well taken. But for systemic JA without MAS, in that case, a short course of corticosteroids till one could bridge to a biologic or obtain a biologic would certainly be acceptable. And that's what we'll say in the guidelines when they're published is the shortest possible, lowest dose possible dose of corticosteroids. Indeed.
Okay. We have one question here. The question here, how long do you wait for response of treatment before tapering or before shifting to another agent?
That is a really excellent question, and we specifically left that number out of there. Previous iterations of the guidelines had actually put time limits, 3 months, 4 months before switching. And the reason that we did not do that specifically is because, at least in the United States, we are held to those guidelines. So if we say 4 months, 4 months is what we're expected to do. And if a patient is rapidly progressing in the wrong direction, we wanted to be able to give practitioners the flexibility to use clinical judgment. Likewise, when we're discussing conventional or non-biologic DMARDs, there are patients who cannot tolerate some of them, specifically methotrexate. And when we are required to adhere to a strict guideline of 3 months, 4 months, the patient really may be doing exceedingly poorly because they can't tolerate the medications. And for that reason, we left this time limit in the hands of the patient and the practitioner. Thank you so much.
Our second speaker, Dr. Ashwag Al-Harthi. Dr. Ashwag is a consultant of pediatric rheumatology. She's certified in pediatric rheumatology. She completed her fellowship at King Abdullah, Specialist Children's Hospital, Riyadh, Saudi Arabia. And Dr. Ashwag will present the new in idiopathic myositis. Dr. Ashwag.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee for inviting me today to present in this great event. Today, I will talk about what's new in idiopathic myositis. I have no disclosures, and I would like to thank these great doctors as my slides adapted from their presentations in the ACR Convergence this year. These are my learning objectives that I will go through during my talk. First of all, to display the phenotypic overlap between the juvenile dermatomyositis and the interferon the interferonopathies, and to share the interferon signature, also to describe the clinical features in the anti-MDA5 juvenile dermatomyositis pulmonary manifestations and the outcomes, and to define the cutaneous gene expression signatures in the juvenile dermatomyositis and identify the unique key genes that differentiated from the childhood onset SLE and other skin diseases. And also to display the role of the JAK inhibitors in the juvenile dermatomyositis, and to highlight the importance of the monitoring the infections, particularly the PK virus in the patients treated with the paracetamol. First of all, I will talk about the juvenile idiopathic inflammatory myopathies. They are heterogeneous immune-mediated disorders characterized by chronic skeletal muscle inflammation as a primary feature. Juvenile dermatomyositis is the most common clinical phenotype of myositis in children, constituting around 85% of all patients with the juvenile idiopathic inflammatory myopathies. It is a rare systemic autoimmune vasculopathy characterized by weakness in the proximal muscles and pathognomonic skin rashes, as shown here in the pictures. It is now increasingly recognized that interferons play a central role to the pathogenesis of the juvenile dermatomyositis and are important drivers of the GDM vasculopathy as well. Also, the myositis-specific antibodies define the phenotypic features and the prognosis within the juvenile dermatomyositis. I will start talking about this abstract titled Anti-MDA5 Positive Juvenile Dermatomyositis, they focus on the lung, presented by Dr. David. And as we know, limited data exists on the pulmonary manifestations of the pediatric patients with anti-MDA5. So their objective was to describe pulmonary manifestations as well as the outcomes in a cohort of patients with anti-MDA5 positive juvenile dermatomyositis patients with a lung disease. So they retrospectively review chart and include a patient younger than 18 years old at presentation. 11 patients were identified, and the mean age at diagnosis was 10 years. And as we can see here in the pie chart, as the majority of the patients between 1 and 5 years, in around 45% of the patients, followed by the teenagers between 15 and 18 years in almost 27% of the patients. Also, this slide is showing that the most common systems affected as initial presentation were the skin in 100% of the patients, followed by the musculoskeletal in almost 90% of the patients, and then the respiratory in 60% of the patients. However, 40% presented without respiratory symptoms, but subsequently found to have lung disease on imaging. They found that all patients presented with the cutaneous lesions, and the most common cutaneous manifestation was non-specific erythema in almost all the patients, in addition to one of other dermatological manifestations. And this is a figure that's showing the skin manifestation in almost 2 patients in their cohort. This slide showing the musculoskeletal manifestations, and as we can see here, the most common manifestations were the arthralgia and arthritis. However, weakness was not present in all the patients in the cohort. And on the right is the laboratory values for the patients enrolled in their study. And as we can see here, it should be highlighted that CK here was not much elevated in comparison to the other muscle enzymes and lab. This slide is showing that to demonstrate the pulmonary manifestations and the outcomes in the cohort of the patients. They found that the cough and shortness of breath were the most common pulmonary symptoms in their cohort. And they found that 4 patients required respiratory supports. Of those, 3 patients with the rapidly progressive interstitial lung disease and all of those 3 patients were toddlers at presentation younger than 25 months. 2 of those 3 patients required ECMO and ultimately died because of the respiratory failure and the diffuse alveolar damage that refractory to extensive immunotherapy, immunomodulatory medications. And the remaining 1 patient with rapidly progressive interstitial lung disease required high-frequency mechanical ventilation for almost 14 months and then fortunately survived, and they were able to discontinue all his therapies. And as we can see here, all the patients had abnormal chest CT findings, and the most common abnormality was the ground glass opacity, and in addition to other lung abnormalities in some patients. So in conclusion, anti-MDA5 positive juvenile dermatomyositis has a distinct clinical presentation of lung disease, cutaneous ulceration, and minimal muscle involvement. Severe fulminant disease can occur with the rapidly progressive interstitial lung disease that was fatal in 2 out of the 3 cases in their cohort, and this indicates a need for further studies on this variant of the juvenile dermatomyositis, specifically the treatment options and the investigations of the younger patient who seems to have a high risk for the severe disease. Moving to this abstract, which has been published by Dr. Hannah Kim and her colleagues and presented in the ACR Convergence this year, which display the phenotypic overlap of some clinical features of Candle and Savy with the juvenile dermatomyositis that led to compare interferon-regulated gene score in these diseases. It has been found that overall, there are multiple clinical features that overlaps between the juvenile dermatomyositis as well as the Savy disease. This includes dysnotable myositis and more skin ulcers and interstitial lung disease in the Savy patients compared to the juvenile dermatomyositis patient. Juvenile dermatomyositis patients had a higher 28 interferon-regulated gene score than patients with the NOMID and healthy control, and a lower interferon-regulated gene score than the Candle and the Savy patients. However, the juvenile dermatomyositis highest quartile subgroup of the juvenile dermatomyositis patient did not differ from the Candle and Savy patients. And the graph on the right side is showing that the interferon-regulated gene score for each of the MSA groups that were higher than in the patient with the NOMID and healthy control, and also the interferon score of the juvenile dermatomyositis patient with anti-MDA5 autoantibody positive subgroup, and the MSA negative patients are lower, but not statistically different from the Candle and Savy patients. Then they looked at how the juvenile dermatomyositis compared to interferonopathies in variability as assessed by the principal component analysis. And this graph, in each marking represents an individual interferon score, and it has been divided to disease groups. The circles represent in each group, including Candle in pink, Savy in red, and juvenile dermatomyositis in blue, where the dark blue for the highest quartile subgroup and the light blue for other MSA subgroups. And as we can see here, the juvenile dermatomyositis overlaps more with the Savy than the Candle, and also anti-MDA5 GDM patients show almost near complete overlap with the Savy, in contrast to other subgroups of GDM, which also overlap more with the Savy, however, to a lesser degree comparing to the anti-MDA5 subgroup. When they looked at the interferon gamma ratio, the juvenile dermatomyositis patients with elevated interferon-regulated gene score have a significantly higher ratio versus the Candle patient, and also have a higher ratio than the Savy ratio. So in conclusion, type 1 and type 2 interferon increased in a patient with the juvenile dermatomyositis, and multiple clinical features that overlap between GDM and interferonopathies, specifically MDA5 antibodies subgroup of GDM, as well as the SAVI patient. Also, the interferon-regulated gene score and the juvenile dermatomyositis patients have a pattern more similar to the SAVI than the candle patient, pointing to a potentially larger role of STING activation and interferon beta in the juvenile dermatomyositis, and a potential treatment target in this group. Now moving to the skin, and this abstract presented by Dr. Jessica Turner in the ACR last month. And the article has been accepted for publication 4 days ago on 10th of December, titled Comparison of the Lesional Juvenile Myositis and Lupus Skin Reveals Overlapping Yet Unique Disease Pathophysiology. Previous gene expression studies in the dermatomyositis and juvenile dermatomyositis demonstrate a prominent interferon signature. The objectives of this study were to define the cutaneous gene expression signatures in the juvenile myositis, as well as to identify the key unique genes that differentiate the skin disease in the juvenile myositis from the childhood onset systemic lupus erythematosus. The final cohort consisted of 15 juvenile myositis patients. Of these, 9 was lesional skin biopsies and 6 non-lesional skin biopsies, and 7 SLE skin biopsies obtained from 5 patients, and also the 8 control skin biopsies sampled obtained from the control patients, healthy patients. And as we can see here, the disease duration had a significantly shorter, the juvenile myositis lesional patients had a significantly shorter disease duration at the time of biopsy than the non-lesional patients. Also, the juvenile myositis non-lesional patients were more likely to be on oral steroids, mycophenolate mofetil, hydroxychloroquine, and IVIG compared to the lesional patients. And overall, the treatments was similar between the juvenile myositis lesional and the SLE patients, with only difference being the more SLE patients on hydroxychloroquine at the time of the skin biopsy, as marked in bold here, the p-values. And it can be, and here it can be seen here that the 2 juvenile myositis lesional patients had myopathic disease, and of these lesional and non-lesional patients tested for the presence of myositis-specific autoantibody, the majority were MSA positive, and they exclusively demonstrated NXP2 and TIF1 gamma antibodies in the cohort. This slide is showing that the majority of the upregulated genes in juvenile myositis lesional compared to the control were interferon sensitive genes, and most non-lesional skin lacked a prominent interferon signature, and also the juvenile myositis lesional and the SLE skin share a highly similar gene expression pattern as shown here in the figure. And they found, or they identify 28 unique differentially expressed gene in the juvenile myositis lesional skin. The top most significant unique differentially expressed genes included FBLN2, CHKA, and SLURP1. The 3-gene juvenile myositis skin signature score was calculated using these 3 most upregulated genes, and they found it higher in the juvenile dermatomyositis and dermatomyositis patients, marked in red here in this figure, compared to other skin diseases. The skin-directed interferon scores were calculated as well, with 18 genes specifically upregulated in the keratinocytes upon interferon alpha stimulation. And they found that the childhood SLE has higher interferon score than the juvenile myositis lesional patients, but not significant. However, lesional skin has significantly higher interferon score than the non-lesional skin biopsies. And here we can see that the SLE, childhood SLE skin demonstrates increased expression signatures from multiple inflammatory cells, including T cell, B cells, macrophages, and plasmacytoid dendritic cells compared to the juvenile myositis lesional patients. And also the juvenile myositis lesional skin show increased expression signature from macrophages and CD4 T cells compared to the juvenile myositis non-lesional patients. And here, when they looked at the interferon score with the clinical variables, they found that interferon scores in the juvenile myositis did not differ based on the individual skin disease manifestation or the treatment status. And also the interferon scores did not differ based on the presence or absence of the MSA antibodies. However, the NXP2 juvenile myositis patient have a higher or significantly higher interferon score than the negative patients, NXP2. And also the increased overall number of serum muscle enzymes was associated with higher interferon scores. So in conclusion, striking interferon signature in the juvenile myositis lesional skin has been identified, similar to previous gene expression studies in juvenile myositis muscle and peripheral blood. Juvenile myositis lesional skin was found to have a predominant type 1 interferon signatures, whereas the childhood SLE lesions also has a central interferon gamma node. A candidate juvenile myositis specific skin signature was derived using these unique upregulated genes. And NXP2 juvenile myositis patients demonstrated a higher interferon score in lesional skin. Now I will talk transitionally why are we need new treatments in the juvenile dermatomyositis. New treatments in juvenile myositis are needed. As we know, this condition is behaving like a chronic, continuous, and relapsing remitting disease with the difficulty to taper the steroid in some patients, and other patients that have combination therapy required. And also the disease activity and the damage may persist into the adulthood. Even if the patient reaches a state of remission, he or she might still experience persistent deconditioning and fatigue. Also, the current conventional treatments often have a significant side effects like steroid, methotrexate, and other biological agents. Now I'll talk about the JAK inhibitors in the juvenile dermatomyositis. First of all, the JAK Janus kinases are members of tyrosine kinase family, as we know, including JAK1, JAK2, JAK3, and tyrosine kinase 2. They mostly work in pairs, and it is critical for many cytokines, as shown here, and other figure on the right, showing the cytoplasmic domain of type 1 and type 2 cytokine receptors that bind to different JAKs, which are activated upon cytokine binding. And the JAK inhibitors targets multiple cytokines, including type 1 and type 2 interferons. Also, the JAK inhibitor will work at this level, as marked in the red, through which it blocks the STAT phosphorylation and downstream interferon gene expression and the protein production. This slide is showing the different selectivity of the JAK inhibitors toward type 1 and type 2 cytokine receptors. And as we can see here, for example, tufacetinib blocks JAK3 and JAK1, and to a lesser degree JAK2. So it has selectivity remarkably sparing other kinases, resulting in highly specific JAK compared to other JAK inhibitors, like baricitinib and ruxolitinib, which, as we can see here, blocking all types of cytokines. Now I'll talk about some of the previously reported cases that show the effect of JAK inhibitors in refractory juvenile dermatomyositis. And this is the first report of the successful use of ruxolitinib in a child with refractory juvenile dermatomyositis that showed improvement in these measures listed in the table after 2 months of the ruxolitinib. This is another case reported on 2019 that showed the effectiveness of the parasitinib on the refractory juvenile dermatomyositis. And also by reviewing the literature, there are some other reported cases that confirm the preliminary effectiveness of the JAK inhibition and the juvenile dermatomyositis, as well as the dermatomyositis. And some of these reported some improvement on the interstitial lung disease as well, and the calcinosis. But I cannot go through these reports as our time is a little bit limited. So I will move to this interesting recent compassionate use trial, whose finding was published by Dr. Hannah Kim and her colleagues at National Institute of Health. They reported the first comprehensive prospective evaluation of the JAK inhibition with the baricitinib in the juvenile dermatomyositis, where they show the effectiveness of JAK trial. They enrolled 4 chronically active juvenile dermatomyositis who failed 3 to 6 immunomodulatory medications, 1 patient with the anti-TIF1 gamma, and the other two patients with the NXP2 antibodies positive. The mean age at start of the baricitinib was 14.2 years, and the mean disease duration was 5.7. The baricitinib dose ranging between 4 and 8 milligram per day, dosed by weight and the renal function. Biologics other than the IVIG were washed out, and other medications continued. The patients have been assessed before and then at 4, 8, 12, and then 24 weeks after the baricitinib. What they found was really encouraging. The figure on the left showed the CDASI in activity score, in which all the patients are showing at least some improvement. Particularly 3 of them are showing dramatic improvement. And the other figure on the right representing the dual imaging of each of the 4 patients enrolled in the study, with the same part of the body at baseline on the left compared to the after 24 weeks on the right. And as we can see here, it has been shown significant improvement in the heliotrope rash, as well as the dilated and tortuous nail fold capillaries, and complete disappearance of the violaceous rash in the lateral thigh and proximal leg. And although there is no total clearance of the severe scaly V-sign rash in the chest, there is some significant improvement. These are different ways of measuring how active the juvenile dermatomyositis patients were. And as we can see here, all showed improvement. The graph A and B are the physician and patient rating of the disease activity on the 0 to 10 scale. The scores were going down with time, indicating the improvement. And the graph C showed the manual muscle testing. And as we can see, 2 patients with the baseline weakness showed some improvement by week 4, as shown in the manual muscle testing, and continued improvement by week 8, and then after, confirmed by the MRI assessment. Here is the interferon markers that decreased in all patients with reduction to normal by week 4 in almost 3 of the 4 patients. And 1 patient had a peak of interferon marker at week 12, as we can see here in the red, with a suspected viral infection, not associated with other signs of disease activity, which is can be a little reassuring, as it showed the good response against the viral infection in the context of the baricitinib treatment. There was no significant change in the muscle enzymes as well, reported in their trial. However, some had variable elevations with a stable or even improved strength. Daily corticosteroids were decreased, and other immunosuppressive medications were decreased or discontinued, and there were no flares or worsening requiring increasing the immunosuppression, and there was no notable change in the calcinosis as well. Regarding the safety, generally consistent with the known profile, no serious adverse events reported in their trial, and no patient withdrawn from the study because of the adverse events. The infection was the most common category in the report, and the upper respiratory tract infection was the most common infection. However, a BK viremia detected in one patient, and the BK viruria detected in other patients. But no significant pathology due to the BK virus has been reported in their trial. Cell count abnormality was another side effect that has been reported in their trial. And also muscle enzymes elevation has been noticed in the context of stable muscle strength in 2 patients and improved even strength in other 2 patients with no signs of active disease in the MRI. So in conclusion, these results indicate baricitinib was clinically beneficial and safe in refractory juvenile dermatomyositis, extending the previous case reports. Baricitinib safety generally consistent with the known profile. However, infections and cell count should be monitored carefully, particularly BK virus infection. Muscle enzymes may not correlate with the strength. However, clinical assessment or assessment by MRI is important in this patient with myositis treated with the baricitinib. And although this study was only on 4 patients, but the data presented demonstrated a considerable promise for JAK drugs in the juvenile dermatomyositis. So moving to this abstract that has been presented by Dr. Jedick and the ACR last month, I mentioned just to highlight the importance of the BK virus monitoring in patients treated with the baricitinib or the JAK1 and 2 inhibitors. However, this trial was in the interferonopathies patient, not the GDM patients. As the reactivation of the BK virus in the urine has been reported previously, but no longitudinal data on the persistence and the safety. Their objectives were to determine the prevalence of the BK viral reactivation in the blood and in the urine in these patients, and to assess the impact of the BK viremia on the renal function as well. The enrolled patient received baricitinib and prospectively monitored for the BK toxicity since 2015 after detection of the index patient with the BK nephropathy, after which they start monitoring the patient for the renal function and the viral load. Also, they monitor the viral load and the renal function in those patients. They found that 87% had the BK viruria and 60% had BK viremia, and all patients had a stable renal function over a mean of 4.9 years on baricitinib, except the index patient. 2 patients also had a BK viremia prior to baricitinib. 1 patient was on tacrolimus and the other was on azathioprine, and 10 additional patients developed viremia after a mean of 1.7 years on baricitinib. As we can see here, these graphs are showing the 2 patients who received baricitinib only. The PK viral load in the blood, marked as the black lines, was correlated with the baricitinib dose in red lines. And this graph detects the viral load in the urine for the patient who had no BK viremia on the left, and the patient who have low but unquantifiable viremia on the middle, and the patient who had quantifiable viremia on the right. And as we can see here, the degree of the viruria correlates with the BK viremia. And in the large proportion of patients with the BK viral load and the urine of more than log 4, the patient turned to have a detectable viremia. These figures are showing the renal function assessment with the estimated GFR and the serum creatinine in the top panel, and the associated BK viral load in the blood in the bottom panel. And it can be seen easily that the estimated GFR decreases and the serum creatinine increases with an increase in the BK viremia. And the log4 was a reasonable cutoff for their patients in this. So in conclusion, the PK, their trial suggests that the PK viral load should be monitored on the paracetamol, and also the presence of the PK viremia and the viruria prior to the paracetamol treatment suggests the evaluation of the PK viral load in patients on other chronic immunosuppressive regimens. Now it's worth to list some of the ongoing researches that has not been presented in the ACR convergence this year, as the data was not yet available for review. However, the details has been mentioned in the new drugs in the myositis symposium that has been held 2 months ago. First one is a pediatric study at the George Washington Medical Faculty Associate by this great clinical trial team. Dr. Rodolfo Corral talked about this study, and he detailed the inclusion and exclusion criteria for the clinical trial in that symposium, but the data is not available now for review. This actually derived from the data in the adult dermatomyositis that showed significant improvements at the 3 and 6 month in corset measures, including the patient global activity, manual muscle testing, CK, and extramuscular global activity as well. And this study showed an encouraging results with the lower disease activity in nearly half of the patients at 3 months with no new safety signal. This is another ongoing open-label study at National Institute of Health by the principal investigator, Dr. Adam Schiffenberg, and his colleague. They are enrolling patients with a GDM and dermatomyositis in the adults who are, 7 years or older, with a moderate to severe calcinosis and extensive calcinosis at least 2 extremities of the or the torso. And overall summary, as closing remarkings, myositis-specific antibodies define the phenotypic features and prognosis within the juvenile dermatomyositis. However, younger age associated with more severe interstitial lung disease and rapidly progressive disease. A striking interferon signature in the juvenile myositis lesional skin has been identified, and in XP2 juvenile myositis patients demonstrated a higher score in the lesional skin. The interferon score in the juvenile dermatomyositis has overlaps with the interferonopathies, as well as the clinical features. And the preliminary data suggests that JAK inhibitors are clinically effective in refractory juvenile dermatomyositis, with notable decrease in the interferon markers that indicates the in vivo effect of the JAK inhibitors in the juvenile dermatomyositis. And the JAK inhibitor was generally safe and well tolerated in their trial. However, infection and cell count should be monitored carefully, particularly the BK virus. I think I'll stop here, and thank you for your attention.
Thank you very much, Dr. Ashwag, for this excellent presentation. While waiting for a question from the audience, I can start with one question. Dr. Ashwag, knowing that interferon signature has been shown in JDM, in blood, muscle, and skin, as you presented in your review, and also it's associated or correlated with disease activity. Do you think that idiopathic inflammatory myopathies need update classification? Another way, do you think these findings will have any implication in the classification in future?
Okay, thank you for your question. This is great, actually, to mention. Right now, there is no update for the classification of idiopathic inflammatory myopathies. However, with the era of molecular genetic findings, it might happen. Yes.
Okay. Other question, Doctora, based on the evolving findings associated, namely associated interferon signature myositis specific antibodies, can we postulate that JDM is a heterogeneous group of disease rather than single disease? You showed us patients with specific antibodies, probably they have poor outcome, or maybe they have different phenotypes comparing with those who are negative.
Yes. Actually, as we know, the myositis-specific antibodies define the clinical feature phenotypes and the prognosis within the juvenile dermatomyositis patients. And however, the available data are limited in juvenile dermatomyositis, but it actually showed that it is a heterogeneous group of with disease.
Okay.
Yes.
Thank you, Doctora, for this answer. I don't see more question, but probably I can ask you, Doctora, this is more practical question. Since now JAK inhibitor become more, let us say, popular in different disease entities, where do you see JAK inhibitors in the list of treatment options for JDM?
Yes. Currently, all the reported data that I reviewed showed efficacy of the JAK inhibitors in the refractory juvenile dermatomyositis, as well as the associated interstitial lung disease and the calcinosis. But in the future, it might be one of the initial treatment in the juvenile dermatomyositis. But of course, further studies in the juvenile dermatomyositis and the JAK inhibitor required before that.
But at least from the review, those patients started on JAK inhibitor considered as refractory cases. So probably yes, it will be considered as maybe third line treatment.
I mean, yeah, for the refractory patients, yes. All the, I mean, the reported cases that I have mentioned in the presentation was refractory, and some of the, also by reviewing the literature, some of the reported cases, a beneficial effect of the JAK inhibitors in the calcinosis and the interstitial lung disease in the MDA5 in the adult patients as well. Yeah.
Doctora, I'm not aware about, I mean, is it available in our country, how to assess for PK, viremia or biuria? I'm not aware if it's available to monitor this. Do you know any data or maybe any information about if it's available in Saudi Arabia or
yeah. Not? I'm not sure about all the centers if they have this way of monitoring of the PK virus in the urine or in the blood. However, I have been, we requested before in the National Guard Hospital in Riyadh. It is available there.
Okay, there is no more question. Thank you very much, Doctora, for this excellent presentation. Probably we have to move to the third speaker. Our third speaker is Dr. Lujain Akbar. Dr. Lujain is a second-year Pediatric Rheumatology Fellow at King Faisal Specialist Hospital, Riyadh. She finished her residency training from King Fahd University Hospital in Eastern Province. I should say special thanks for Dr. Lujane for accepting this invitation within short notice. We asked her to present this last week. So she did a great job in preparing and present this topic. I should say Dr. Lujane has a special interest in childhood lupus as well. Dr. Lujane will present life-threatening complication of childhood lupus. Also, she will talk about evaluating damage in childhood SLE. Dr. Lujane.
Assalamu alaikum and good evening. I would like to thank the organizing committee for inviting me to speak today. I'm pleased to be part of this conference. So today, my topic will be the serious complications and disease damage assessment of childhood lupus, what was new from ACR 2020. I will go over the following topics: the thrombotic microangiopathies in childhood lupus, the macrophage activation syndrome in childhood lupus, and pediatric considerations in assessment of SLE damage. So starting off with TMA or thrombotic microangiopathy, we will just touch briefly on it, and we will talk in specific on TTP. So what is TMA? TMA is a descriptive term for endothelial cell injury or blood vessel injury. So in damaged endothelial cells, there will be platelets clumping and thrombus formation, which leads to a pentad of thrombocytopenia due to the platelet clumping, as I mentioned, hemolytic anemia or microangiopathic hemolytic anemia due to the shearing forces, and end-organ injury due to the microthrombi, most commonly or typically renal injury, acute kidney injury. So the differential diagnosis in TMA is very wide. However, if we face a patient with TMA, it's important to step back and just divide it or break it down into groups. In regards to rheumatological diseases, we can divide the causes into primary TMA and secondary TMA. Why is it important to know the difference? Because the primary TMA, there is a specific cause with a specific therapy or possible specific therapy, while in secondary, you can treat the manifestations of the disease. So in primary TMA, as you can see, it can be divided into hereditary and acquired. We'll go over the pathology or the cause in a second. And secondary TMA can be due to lupus itself or antiphospholipid antibodies or infections. So what is TTP, or the thrombotic thrombocytopenic purpura? It is in a usual or in a normal situation in the blood clotting process, the von Willebrand factor protein will attract the platelets, as you can see in the image here. So they will form a clump. However, in normal situations or normal individuals, the ADAMTS13, which is an enzyme, it cuts up the von Willebrand factor into smaller pieces, preventing the platelets aggregation or recruitment and preventing the blood clot formation. In patients with TTP, there is a deficiency in ADAMTS13 in cases of hereditary or mutation in ADAMTS13. So the von Willebrand factor will form long and large multimers, attracting or recruiting the platelets and forming thrombi. In the acquired TTP, the cause is anti-ADAMTS13 antibodies. The classic pentad that we know of TTP is the fever, thrombocytopenia, hemolytic anemia, again due to the shearing forces, renal impairment, neurological abnormalities. However, this is not exclusive only for patients with TTP. Patients might present with GI manifestations, including diarrhea, vomiting, and abdominal pain, as well as cardiac. So some patients can have arrhythmia with sudden death or MI. In adult literature, they found that patients or adult patients who present with high troponin on diagnosis of TTP or on presentation, they will have higher mortality and worse outcome. The important number in TTP to remember is 10%. So if the activity of ADAMTS13 is below 10%, then we should suspect either deficiency due to mutation or secondary due to an inhibitor or autoantibody. So now that we know that TMA is a heterogeneous group of diseases presented by SLE TMA, immune acquired or acquired TTP, primary TTP or HUS and antiphospholipid Tma, and that some lupus patients may have either SLE Tma without an underlying cause, or they might have Tma due to antiphospholipid or immune TTP due to the antibodies. So there is an overlap between those entities, lupus and Tma. This was a study that showed that the prevalence or the incidence, in TTP in pediatrics is much more lower than that of adults. It is rare in general. It's 30-fold lower than that in adults. An important thing to mention in that systematic review was that patients with TTP were diagnosed with lupus either before presentation with TTP or during presentation, or after that, even up to 50 months following TTP. So it is very important in any patient with immune TTP, the lupus might declare itself. So we have to follow these patients and keep high index of suspicion with them. The earlier studies in the immune TTP concluded or suggested that patients with SLE and immune TTP have a greater likelihood, or they are more prone for mortalities and have worse outcome. However, in a recent study in 2020, they concluded that patients with lupus TTP have more likelihood of remission than the primary TTP. And the number is few, however, it is one of the very few studies that measured the ADAMTS13 level. So we know for a fact that these patients have immune TTP, while in the previous studies, we're not sure whether this is TTP or TMA. So we might just say that patients with lupus and TTP are not in higher risk than patients with a primary TTP from this study. A case was presented in brief. I'll go over it in brief. A 14-year-old Asian male presented with history of abdominal pain, back pain, anorexia, and arthralgia for 3 months. He presented recently with fever. His labs showed anemia with a picture of hemolytic anemia, including severe schistocytes, low haptoglobin. However, the direct Coombs test was negative. He had thrombocytopenia as well. He had elevated creatinine, microscopic hematuria, and nephrotic range proteinuria. He was investigated for an underlying cause for TMA and was found to have low complements, positive ANA 1/640, and double-stranded DNA with anti-Rho. So he was diagnosed with lupus. A renal biopsy confirmed lupus nephritis class 3A and multiple fibrin platelet thrombi, which is suggestive of TMA. So after the diagnosis, they started management. They sent for the ADAMTS13 activity, which became low. However, it is important to start management even before the result come back. So they looked for an inhibitor or an antibody, which was present. So the patient's diagnosis was lupus and immune TTP with lupus nephritis as well. How do we treat immune TTP? The therapeutic plasma exchange, or PEX, was studied a long time ago in 1991 with an RCT. They found that patients who received plasma exchange versus patients with plasma alone had a higher recovery of platelets and survival at 6 months. The idea behind it is that it is believed that it replenishes the ADAMTS13 activity and removes the antibodies for ADAMTS13 and ultra-large von Willebrand factor, as well as the inflammatory cytokines. The definition that was, or the patients were defined as complete remission if they sustained a platelet count of 150 and above for 2 consecutive days, which is also the practice in lots of hematology colleagues. So the platelet count of more than 150 on 2 consecutive days with no new organ involvement or deterioration. Corticosteroids, in brief, the high dose or higher doses of corticosteroids were found to be more effective, or patients had a higher remission rate with higher doses than the standard dose. Biologics, including rituximab, which is one of the commonly used in TMA and worldwide. So it is believed to suppress the anti-ADAMTS13 antibodies production. Compared to the standard of care, retrospective studies suggested that it decreases the chances of relapse. It has a very likelihood of remission, and the dose regimen differs. A new biologic was developed, caplacizumab, which is a humanized anti-von Willebrand factor antibody. It reduces the microthrombi formation, as you can see in the image here. It prevents or blocks the binding of platelet with von Willebrand factor. Two big studies were done by by adult hematology, phase 2 and phase 3 trials. They concluded that patients who received caplacizumab in TTP had more normalization of the platelet count, fewer deaths, relapses, shorter hospitalizations, and fewer plasma exchange needs. So back to our case, or the case that was presented in the conference. They managed their patient with daily plasma exchange till the level of platelets was almost static, above 150, as you can see here. Also, they managed with pulses of steroids for 3 days, followed by oral steroid. MMF was introduced as well for the lupus nephritis. Rituximab, they elected to give rituximab doses every week because the patient was on plasma exchange. So they wanted to reintroduce the rituximab every week. As you can see, all of the parameters improved to this management, including the ADAMTS13 activity level. So in conclusion, in Tma, the Tma differential diagnosis is very wide. However, in pediatric lupus, there are some considerations. So we have to look for the causes. Is it primary or secondary? As the cause is different, accordingly, the management will be different. The prompt initiation of therapy, even before having the results of ADAMTS13, is important. Concomitant therapy with steroids, rituximab, immunosuppression for lupus-related TTP with early initiation, as I mentioned, is very crucial. New therapies are on the way. So now moving to MAS, or macrophage syndrome, in childhood lupus. Macrophage activation syndrome generally is a phenomena that is caused by expansion or excessive activity of predominantly two cells, which are the T lymphocytes and the macrophages, that will lead to cytokine overproduction and hyperinflammatory state. So in patients with active rheumatic disease, there will be an increase in the cytokine levels, leading to a cytokine storm, which will further stimulate the natural killer cells, or the CD8 cells, and the macrophages. The CD8 cells have defects in their killing ability, so to compensate for that, they will replicate and they will furthermore produce interferon gamma. So as you can see, it's a loop of interactions between the cytokines and the cells that need to be broken, or that we need to stop it. So MAS in childhood lupus was rare. However, it is a life-threatening complication of lupus. It is more clinically recognized nowadays, and there is an increasing frequency in lupus. We don't have any validated criteria, other classification, or diagnostic criteria to help us diagnose and treat these patients. So in practice, we are using the systemic GIA MAS guidelines or criteria. So the recognition of MAS in patients with lupus is challenging, because patients with lupus might present with disease activity with concomitant infection, and the picture will be the same as of the MAS. There was a study that compared between patients with systemic GIA and lupus. Both of them, they had MAS. They concluded that MAS occurred early in the disease course in both patients, systemic GIA and in lupus. Patients with lupus had fever. All of them had fever, while patients in systemic GIA, they had a different type of fever. So from the quotidian fever, they became remittent fever or highly grade fever. Patients with lupus had higher frequency of multi-organ failure, including kidneys and cardiac, more than patients with systemic GIA. They had also elevated transaminases and cytopenias. However, their cytopenia was an absolute rather than relative as in systemic GIA. Interestingly, the ferritin level was not as high as in systemic GIA. This might be reflected by the fact that in systemic GIA, there is an intense inflammation. A study that compared between two groups of patients, both of them, they had lupus. One group was defined as patients with definite lupus, with definite MAS, based on bone marrow aspirate finding. and another group is a probable MAS based on, as they did not have any finding in bone marrow aspirate. They were contrasted to patients with lupus without suspicion of MAS. So the finding was, or the conclusion was, that fever is sensitive but not specific in MAS lupus. In contrast to the other clinical manifestations like lymphadenopathy, it was more specific than sensitive. But the best sensitivity and specificity regarding laboratory parameters was with the hyperferritinemia, followed by lactate dehydrogenase, hypertriglycerides, and hypofibrogenemia. So in conclusion, if we see a patient with unexplained fever and cytopenia with hyperferritinemia in a patient with lupus, we should have a high index of suspicion of MAS and start management. From these data, they came with a preliminary diagnostic guidelines for MAS as a complication of lupus. It includes clinical and laboratory and requires the presence of one clinical and at least 2 laboratory criteria. The bone marrow aspirate might be required if there is doubt in the diagnosis of MAS. There is a comparison also in 2018 between patients with MAS and without MAS. In brief, MAS group patients were found to have lymphopenia more and thrombocytopenia with higher anti-double-stranded antibodies compared to patients without MAS with a high p-value. In a retrospective cohort in 2020, they wanted to define, or they wanted the best discriminators for MAS and lupus. They had 2 cohorts, cohort 1, cohort 2. So cohort 1 found that the best discriminator for MAS and lupus was a ferritin level of more than or equals to 699, while cohort 2 defined, or the best discriminator was ferritin more than 1,107, followed by lymphopenia. In conclusion, the decision rules demonstrated improved performance compared to the preliminary guidelines for MAS and SLE from the lupus working group and PRESS and familial HLH. However, the validation of these criteria needs a cohort studies. So the treatment in MAS studies are not a lot. There are few of them. Here are 3 important studies. As you can see, steroids was used in 100% of patients treated for MAS, followed by cyclosporin A. Also, IVIG was introduced as well. Patients who had severe disease, some of the studies they used anakinra, and some of them they used others like MMF. The important message from one of these studies was the late referral and the late initiation of therapy, even after the suspicion of MAS, led to higher mortality and poorer outcome. So in conclusion, differentiating disease activity from MAS is very challenging, especially if the patient is coming with concomitant infection in lupus. MAS have been more clinically recognized nowadays. However, we do not have validated diagnostic or classification criteria to help us in diagnosis and even in establishment of the guidelines for therapies as well. And once we suspect a patient with MAS by high ferritin or no response to therapy, we should keep a high index of suspicion for MAS, and treatment modalities are still emerging. Now switching gears to SLE damage assessment. So why do we use the damage index in lupus? Because of the important reduction in mortality among patients with lupus, patients who survived longer than 10 years, they were found the cause of death is unlikely to be simply due to active lupus. So in one of the conferences, the Conference of Prognosis Studies, it was a long time ago in lupus, they concluded that in order to describe the prognosis in lupus patients, we need to evaluate three things in a patient: the accumulated damage, the disease activity, and the health status. So they came up with a damage index, and it underwent a long validation process. And finally, in 1997, the SDI, or the SLIC ACR damage index, was validated. So the in SDI, the attribution to SLE is not necessary. However, it should be after the diagnosis only of SLE. Irreversible permanent organ dysfunction more than 6 months only is considered as items in this index. It includes more than 12 organ systems with a maximum potential score of 45. It is a reliable method, or it was found to be reliable in multiple studies over the years, as it was found to predict the mortality in lupus patients as well as the future disease damage or disease-causing damage in lupus. However, there are limitations, as with every endings. We will discuss the limitations now. The dynamic range, as I mentioned, the highest score or highest possible score in STI is 45. This is a summary of a cohort over the years that was done even up to 20 years. They followed the patients. As you can see that the highest scored score was 2.5 even after 20 years. So there's a significant floor effect if you compare it to the highest maximum score. The other thing is the item definition. So when they validated the items, or when they considered the items during validation, there were no modalities available everywhere as nowadays. So they depended mostly on the clinical criteria. For example, pulmonary, they depended on the auscultation finding. However, now we have echo, PFT, and catheters to define pulmonary hypertension, as well as, for example, osteoporosis. Now we have BMD. Before they considered the item with a radiographic finding only. So we might consider these definitions, or the new definition of the or the potential definitions of the items. Range of the items. So the range of the items, some of the items included do not have high frequency, or they have low frequency. And some of the items were not included that might affect the disease prognosis or the disease itself, like thyroid diseases or Zika syndrome. So we might put this in consideration, or in the next for the next index. 6 months duration. Specifically in pediatrics, a 6 months duration, patients might have irreversible damage, especially with the pediatric population. They have a regeneration, higher or greater regeneration process. The item window. So as I mentioned before, it is important, or it is one of the validation criteria that the patient or the disease manifestation are counted only after the diagnosis of lupus. However, whatever happened before the lupus was not counted. We know now that there is a prodromal period before lupus and autoantibodies formation. So we might consider them, or they might consider that in the updated ones. Weighting of the weight of the items. Actually, in the validation process, they considered the weight of the items. But they concluded that it will take longer time, and it was only modestly higher in predicting the damage than the unweighted score. So the validation ended up with an unweighted score. But if we can compare, that is for example, cataract prognosis, and the effect of cataract on the disease itself is as MI or stroke. Pediatric items. There are important aspects in pediatric that were not considered in the STI. That includes growth failure and delayed puberty. So in 2006, a group of experts came up with the pediatric specific STI. They included, in addition to the domains, growth failure and delayed puberty. The growth failure is defined as height below the 3rd percentile for age, growth velocity over 6 months below the 3rd percentile for age, and crossing at least 2 percentiles on growth chart. 2 of them at least should be considered, or should be present. The delayed puberty is a delay in the development of the sexual characteristics more than 2 standard deviation below the mean for age by Tanner staging. Of course, it is important to measure the final height and compared to the mid-parental height to assess the damage or the irreversible damage for the growth in children. And it is advisable also to use the national growth chart instead of the international growth charts. Using the above pediatric specific SDI definitions, we can see that patients or females or males who were diagnosed at during puberty or around the puberty, they were found to have delayed puberty, either the onset of puberty or progression of puberty. It was 25% delay in the onset of puberty compared to 15% in females, and the progression was delayed in 44% of males compared to 38% of females. And 25% of the males had substantially stunted height, at least in 25, and 15% in females. Also, there was a greater risk of substantially reduced final height in girls who were diagnosed at the age of 11 to 13 years. They had 11 times higher risk than other patients with lupus. So in conclusion, the STI predicts the outcome in lupus patients, whether it's mortality or it's the future damage. There is also some limitations that we discussed earlier, including pediatric concerns of the growth and puberty abnormalities. So a pediatric specific damage index might need to be validated to assess the damage in pediatrics. And by this, I conclude my presentation. Thank you very much.
Thank you very much, Dr. Olajim, for this outstanding presentation. I didn't see questions, but probably just small comment about disease damage index. As you know, children, they are different ages. So probably damage index needs updating to be age appropriate, especially in certain domains, namely cognitive and puberty. I have question here. Is there any relationship between lupus anticoagulant level, hypothromboanemia syndrome, and thrombotic microangiopathy disease?
Well, there is in general a relation between antiphospholipid antibodies, antiphospholipid syndrome, and the microangiopathy hemolytic anemia in lupus. However, in specific lupus anticoagulants, I'm not sure.
Okay. Doctora, can you comment about this? Is, I mean, general question, but people, they may ask about, is there a specific timing for plasma exchange and using immunosuppressive medication, including rituximab? Could you comment about the timing frame?
Yeah, from what I came across in the review, depending on the patient's situation. So if the patient is critically ill, we should initiate PEX as it's one of the therapies, and we should initiate it fast, even before the ADAM TS13 level comes back with the suspicion of TTP. So it depends on the patient's situation, but there is no like cut-off or no specific timing for plasma exchange or immunosuppression as well.
Okay. Regarding MAS in lupus, probably as a rheumatologist, we are more familiar with the methylbrate, while in our colleagues from hematology oncology, when they treat HLH patient, they used dexamethasone. Do you see any need to consider dexamethasone, especially in certain condition in lupus with MAS?
Well, as you mentioned, doctor, usually the hematology, they're using the dexamethasone. However, it might be beneficial in cases of CNS involvement, as it showed more benefit with the CNS involvement. Other than that, I would say that's my answer.
Okay, thank you, Doctor. You said, Doctor, there is no validated criteria for MAS in lupus. Most people, they use the same one for systemic GIA. But do you know if they have similarity in terms of cytokine profile between SLE and systemic GIA MAS?
Well, there is similarities, yes, but it's not definitive. So still there is no targeted therapy for MS and childhood lupus. As I mentioned in the studies, for example, we're using anakinra mostly for systemic GIA with the steroid. However, in systemic lupus, anakinra have been used in only severe cases not responding to the initial therapy, which was methylprednisolone, usually pulses and then some of the patients they use with them cyclophosphamide and also IVIG. So there might be similarity, yes, but it's not to the extent that we can target therapy.
Okay, thank you very much, Doctora. There is one question from the audience. What has been the most important practice changes, maybe practical changes, update for your practice in pediatric lupus during the past year?
Can I get the question again, please?
Yeah, it seems this is general condition. What's the most important changing update?
Updates, I would say that maybe the approval of biologics, or now that we're accepting biologics more. So the first biologic, which is belimumab, was approved in 2019. So now maybe other biologics are on the way to be approved. So.
Okay, thank you very much, Doctor. And I may add one thing soon it will come, the use of corticosteroid for SLE, childhood SLE, especially with nephritis. The manuscript will come soon. It's like guidelines how to use the steroid, how to taper it. This is international collaboration work. So hopefully it will come soon. Doctor, let us move because of the time, just for the disease damage index. You mentioned there is probably a difference between male and female regarding the puberty and growth delay. Is there an explanation for that?
Well, it might be because it might not be accurate, I would say, because we're not honestly not every patient who comes to the clinic we're applying the Tanner staging or the puberty staging for them, so it might not be that accurate.
Okay. Back to MAS, one of the audience asked, this is his opinion. He said, I think the cause for MAS in SLE is related to lupus flare. So targeting lupus is more important than targeting MAS. Do you agree, Doctora?
I agree. We should target both. So as in Tmj, I would treat the...
Well, probably I disagree, because MAS is fatal disease. If they don't target it, probably the patient will be in serious condition. So MAS is a complication. So this should be, I mean, definitely you need to treat both, but the main target should focus on MAS because it's a fatal disease or complication, let us say. I think because the time, I think we have to stop here. At the end, I should thank the speakers for the excellent presentation. We heard excellent talks about the new GIA guidelines and the new in childhood myositis. Also, we heard the serious complication of childhood lupus, and also the importance of disease damage assessment. With that, I will probably, if Doctora Hanan Al-Rayis with us, I will leave the floor for her. If not, probably we can stop here, and thank you for all of you for joining tonight with this activity, and hopefully we'll see you tomorrow, inshallah. Have a good night.